Okay, first and foremost, thanks Professor Okasa and the US Egypt and the warm welcome which I have received here, meeting old friends and making new friends here. Today we'll be discussing about tips and tricks to perform a US guided cystogastrostomy. And let me tell you, although when we see live demonstration and we saw an excellent case just before the presentation, it's not easy as it looks actually. When you are doing the procedure, like we were sitting in the audience, it's easy to make a comment, do this, do that, but when you are doing the procedure, when the stent is coming out, putting the wire, it's a nightmare because the wire can sometimes go somewhere else also. So it's not an easy procedure, and maybe the other interventional procedures are less complex than a pseudocyst drainage, because this is the first procedure we all of us learn as an interventional endoscopist. So first and foremost, regarding this presentation, I want to thank to Dr. my mentor who is US, and this presentation is also, I have taken it from him with some modification from my side. So when we are thinking of performing a cystogastrostomy, what we need to understand is the definition of pancreatic fluid collections. How does the pancreatic fluid basically spreads? What are the options of management and the indications, the checklist, how should we do, and what's the follow-up after the cystogastrostomy? So let's see the definition of pancreatic fluid to decide when should we approach for a US guided drainage. So we all know that acute fluid collection is very common after acute pancreatitis. Anything less than 4 weeks, usually we don't touch. Although there are data where you can do a US guided drainage, particularly between 2 to 4 weeks, but those are exceptional circumstances. Usually when the fluid collection is for more than 4 weeks, it has a fibrous wall, and this is the time we can go for a drainage.
Dr. Piyush?
Yeah. Coming to the definition of fluid collections, less than 4 weeks, more than 4 weeks is important to have a well-defined wall so that we can go for the drainage. And obviously we have to look at the clear fluid. Is it just a pseudocyst or is there a necrotic debris which is there? Now, before we think about doing a cystogastrostomy, how does the fluid spreads after the pancreatitis? This is important because we see pseudocyst in the lesser sac, we see it very commonly, but sometimes we see extensive necrosis of the pancreas with collections in the right paracolic gutter, in the left paracolic gutter, everywhere the fluid is there. So we need to understand how does this whole fluid spreads after pancreatitis. So pancreatic fluid spreads into different compartments, which includes retroperitoneal, subperitoneal and peritoneal spaces. So if you look at this image, pancreas is a retroperitoneal organ which is just behind the stomach, and the story starts, as you can see, starts from the retroperitoneal. So it spread posterior to the parietal peritoneum, then to the anterior pararenal, then to perirenal, then to the posterior pararenal. So this is the whole sequence by which the fluid spreads in pancreatitis. Then fluid goes into the subperitoneum, which is basically the ligaments. So this is the embryological ligaments, the subperitoneum. So fluid in the subperitoneum is also known as ligaments, and as you can see, the gastrohepatic, the gastroduodenal ligament, the GHL, the gastrosplenic, the gastrophrenic ligament. So these ligaments are the peritoneum, the hyperechoic ligaments, which also helps in the spread of the fluid. Spread to subperitoneum follows the rules of development in embryology, that is posterior to anterior. So it's lienorenal, gastrosplenic, gastrohepatic, and very, very rarely falciform ligament. So sometimes we have seen cases in our experience where there is collection even in the liver also. So that usually happens after the fluid spreads from the posterior to the anterior going up to the liver. It is usually extensive collection. Coming to spread to the peritoneal cavity through the lesser sac, through the posterior peritoneum, greater sac, entry from the tail of pancreas, which is the interperitoneal part. So we divide the peritoneal cavity into greater sac and the lesser sac. The lesser sac has superior part, inferior part is there, and it has got different recesses are there. The superior recess, the splenic recess, the inferior recess is there. And this is the US image of the recesses, the superior recess, as you can see, the inferior recess, and obviously the splenic recess. So this can be appreciated easily on the CT scan. So as you can see, the superior recess, the inferior recess, and obviously the splenic recess. So sometimes we see a pseudocyst, a big collection going from the lesser sac up to the tail of the pancreas to the spleen. So these are the different way it spreads. if you look at anatomically. So peritoneal cavity, greater sac, supracolic, infracolic compartment. Sometimes we have collection which are big collections near the stomach, but going into the left paracolic gutter. In such cases, we need to do a combined procedures. Besides EUS, we need to do a percutaneous drainage also. So this is the way the whole pathway goes. The one which is relevant to us as an endosonographer is which spreads to the gastrosplenic and gastrocolic and the lesser sac. So these are the one which we are doing through EUS guidance. So cystogastrostomy boils down to subperitoneum, gastrosplenic, gastrocolic ligament, and the peritoneal spaces, which is the lesser sac. So these are the one which we are draining when we are going through the stomach or probably through the duodenum. Coming to the different options, nowadays, as we are aware that it's the EUS which has taken over the surgical, but still there are some centers where they do it laparoscopically also. Now, this is a classical case which is amenable for EUS guided drainage, a lesser sac or a pseudocyst, what we call it, with a well-defined wall. Now, coming to the indication, when we should do a drainage of a pseudocyst, what are the indications? So, we all are aware if it is symptomatic, increasing in size, creating some problems, these are the indication of the pseudocyst drainage. We know the contraindications, less than 4 weeks, wall is not formed. Obviously, there is a coagulopathy or patient is a high-risk patient. Now, what are the checklists? Before we do a EUS guided drainage, we need to understand that we need to check personally, or we should have a technician checking everything for any troubleshooting which we might get during the procedure. So, it is important on EUS, we look at the cyst wall. Is it well defined? Is it thick wall, thin wall? Is there a vessels in the wall? What is the diameter of the wall, the thickness? What's the content? Is it predominantly walled or pancreatic necrosis? Is it a single cyst or multiple cysts which are connected to each other? Is there any sepsis? And devices, accessories, and obviously the electrosurgical settings. How we should do the cystogastrostomy? So these are the system. We need to have the linear EUS, therapeutic, the CO2 insufflation, fluoroscopy, electrosurgical unit. And these are the accessories which we need to have when we are planning to do the EUS guided drainage. So obviously, if we are planning to put a plastic stent, which is the most common method used all over the world, we need to have needles 19 gauge to puncture the cyst. We need to have the guide wires to go through it, the dilator, the cautery system, and obviously we should keep the balloons. So there are different types of balloons which we use, whether it's hurricane balloon or a CRE balloon. We can use dilator system. We can use 6 French cystotome. We can use a 10 French cystotome from Cook also. 8.5 French can also be used. We can use dilator, and obviously it is important to use the pusher also if you want to put 2 wires. Now these are the technical parts, how we should use the needle. So although it looks easy, again as I was telling initially, but there is a way to use the needle also to prevent any complication when we are using the 19 gauge needle. So selecting the puncture site. So how we should select the puncture site? So the site of maximum convexity can be assessed by moving the scope in clockwise and anti-clockwise direction. So it is important that we try to puncture the cyst where it is compressing the stomach wall the maximum, at the point of maximum curvature. Anything beyond or before it will land you with some complication, which may include sometime perforation, guide wire going here and there. If we are exactly at the point, the chances of complications are minimal. Now, how we should take out the needle out of the scope? So obviously we should not do this. Sometimes we have, enthusiastic endosonographers and they want to be aggressive, and now this is a image, which is obviously done by a doctor, and they are aggressive, they are new, they want to learn. But we need to have a supervisor. If you are starting this procedure, someone to guide you. This is important. So taking the needle out of the scope, identify the best position of puncture after rotation. At this point, fix the scope with the help of assistance so that it does not move. Move the up down knob to down. Keep it down with ring finger if you feeling resistance. We will not see the EUS view, but still there is no need to worry. After that, once the needle is out, 3 things we need to check. The endoscopic view, are we seeing the needle on the endoscopic view? or the feel of needle passing out of the channel. And obviously you can see the movement of the needle with the elevator. You can make it up and down to see the needle has come out or not. So these things are important to confirm that the needle has come out of the scope. Otherwise, you may create a perforation or you may create a leak of the scope, which can be very financially not good for any of us. Coming to the opposing with the cyst wall, keep the scope fixed, keep the needle fixed, move the knob up and seek contact with the cyst again. So we made it down, we'll made it again up, and now we can go ahead with the puncture. Again, we have to make sure that the needle is out by the three methods which we have described. Now, selecting the puncture angle. How should we puncture with the needle? At what angle? So while puncturing, consider the angle of puncture. Transmission of power is angle dependent. Try maximum angle by maximum up deflection as well as use of the elevator. And obviously the endoscopic image is important. Ideal will be somewhere between 60 to 70 degree. It's very difficult for us to get a 90 degree when you got a curvature like this. But we should try for at least 60 degree, because when we are 45 or 30 degree, that means we are going away from the wall and this may lead to some subperitoneal perforation. So this is important, that although it looks simple, but this is important, that how is our needle trajectory. And obviously we need to check the position of the scope while we are puncturing it. Avoiding puncture through the diaphragm. Now this is a mistake in the initial someone can make. So how you going to, how this happens, particularly when we are doing just close to the G junction. This is a collection in the superior recess and the puncture was just done below the G junction. And that's why the stent is deployed very higher up. So how to avoid the diaphragm? Obviously, we all of us, before we do the puncture, we always make sure that we are below the G junction. I think all of us go below the G junction to make sure that this. But how to do it endosonographically? So we are all aware that the diaphragm lies just above the celiac artery at around T12 vertebra. So anything below the takeoff of celiac artery, you will never puncture a diaphragm. So if you look at this image, if you are rotating the scope below this level, the chances of puncturing the diaphragm are negligible. So this is important below the celiac artery origin. We need to understand the artifacts of the needle. This is the tip of the needle. This is the missing part of the needle, and this is the reverberation artifact. So sometimes this may create some ghost images of the tip also. So that we need to understand when it is in the water, this is the way the needle behaves basically. These are the grating lobe artifacts which may create some problem to exactly assess how deep is your needle, where you may sometime by mistake go very deep inside the cyst thinking that probably this is the tip of your needle. So we need to understand these artifacts which we'll see commonly. After the needle puncture, the second step is to put the guide wire. Usually we use a 035 guide wire with hydrophilic tip. Make 2 loops of guide wire within the cyst. Sometimes 2 guide wires may be needed, and use of 10 French cystotome, or we can use a 10 French pusher tube to put 2 wires to put 2 stents. So two loops is always the best, and this is the way the wire looks inside the cyst. After we put the guide wire, we need to use a dilator, which could be a cystotome, a 6 French or 8.5 or 10 French. We can always use Schoendra dilators also, or taper tip catheters, which are available from different companies are there. Advance the dilator over the guide wire. Best power transfer is at 90 degree. Dilate by cystotome cannula or the Schoendra dilators. Now how should we puncture with the cystotome? So rule out the presence of vessel, the first step. Take the cystotome out of the scope and check the tip on fluoroscopy. Keep it away from the wall. Apply pure current or auto cut as per the new RB settings. Feel the giveaway sensation of entry into the cyst. See the echogenic turbulence on entry into the cyst. So you will see the echogenic hyperechoic turbulence when the cystotome enters. Then obviously you're going to do the balloon dilatation with either with a hurricane balloon or a CRE balloon. And after that, there will be the deployment of the double pigtail stent is there. Either 7 French, 10 French, or you can always go for 2 7 French stents also. So I'm going to show you a video of a US guided drainage of the pseudocyst here. So we use a 19 gauge ecotip needle for the puncture of the cyst. As already shown in the images, there will be missing part of the cyst. The tip of the needle is important that it is followed up. Then we are putting the guide wire. We are trying to make 2 loops of the guide wire, and obviously fluoroscopy helps us in visualizing the same thing. After making 2 loops of the guide wire, we use a 10 French cystotome, because in UAE at that time we never had 6 French. Nowadays we have it. So we use a 10 French cystotome to go through the wall. You can see that artifact. We use a 8 millimeter balloon to dilate the wall for the dilatation, probably for around 30 seconds. And after the dilatation of the lumen of the pseudocyst, we put a Nagi stent across the cyst for this patient basically. Now coming to deployment of axial stent, the lumen opposing stent. So you can see the endoscopic image and you can see a cyst there. So we are pressing the distal flange of the axial stent across the wall. It goes through the AutoCut settings. There will be deployment of the distal phalange. So as you know, on axios we have 4 markers are there which tells us how to move up and down. So once we have deployed the distal flange, we push it towards the wall to make a umbrella shaped indentation on the wall of the cyst. We need not to push too much inside. We need not to keep it very loose also. After that, we deploy the proximal flange of the axial stent inside the endoscope. Nowadays, they are recommending to deploy it inside the channel rather than, the black marker, which they used to recommend 3 years before. So once you are sure that, the proximal flange is deployed, we go to the endoscopic view. We make the big wheel down. We go either right or left just to give some space for the stent to come out. So now you can see the deployment of the axial stent here in the posterior wall of the stomach with the fluid coming out, and you can see the catheter. Now, what about you've done the drainage, you have put the stent, whether it is plastic or the metal stent, how to do the follow-up? So follow-up for complication is important. We see complication in 5 to 15% of the patient. Higher chances of complication, particularly if there is a necrosis. Bleeding risk 8 to 10% because of aneurysm or a vessel. And this is a video showing if there is a lot of blood vessel in the wall, we need to be careful. And this is a bleed during the puncture of the cyst. You can see the on the color Doppler, and you can see the hyperechoic bleeding happening inside the cyst. How to control the bleeding if it develop? Unfortunately, maybe tamponade, but sometimes we need to go for angiography if it is a massive bleeding, depending on the control of bleeding. This is another video showing a late bleed after the puncture. So again, you can see the bleeding happening, and you can see the blood hyperechoic which is flowing inside the cyst. Infection is also a complication. Sometimes it can happen if there is a necrosis. In such cases, you can always put a nasocystic drain, which we discussed also. If infection fever develops after putting a stent, you need to put a nasocystic drain. Necrosectomy is usually performed after a few days or maybe in the same session. Usually we prefer to be done later on. Now coming to perforation, which is the main worry. As you can see, this is a perforation done by the balloon. Most commonly it happens during guide wire manipulation while exchanging the stent. Large balloon dilatation, like sometimes some people go for 12 millimeter or 15 millimeter. That can sometimes lead to a perforation. Manipulation of a misplaced stent can lead to perforation, or sometimes repositioning of the stem can also lead to perforation. So we need to be careful. That's was the reason seeing the endoscopic view is important after you deployed your needle or the wire. So how does this takes place? Puncture near the border of the cyst. Again, the angle is important. If you are going angle beyond 45 degree, like 35 degree, then you are going away from the wall, and this may create a perforation. Or the puncture was correct, but the balloon was deflected from the cyst wall because of the angle. So this is important. And this can happen by wire also, sometimes going between the walls. What about other problems which we can have? Stent misplacement happens on the time of stent placement, or stent migration, which may happen after the stent placement. Misplacement is also common, 2 to 8%. And this is one of our cases only. This is the internal deployment of the first axios. Unfortunately, we deployed inside. And this is the internal migration. How did it happen? So you can see the video where we are putting the stent inside the cavity. And this is the second Axios which we deployed was 10 millimeter instead of the 15. And this is nice US video showing us both the stent inside. And this is the way we remove the migrated stent after a week. It was a nightmare because we were removing a 15 mm stent through a 10 mm Axios stent, but fortunately it went well and the patient went home safely. So these are the troubleshooting which we can land up, while we are deploying the lumen opposing stent basically. This is another video showing stent migration into the cyst cavity, which is retrieved with a biopsy forceps. Buried lamps is also a phenomena which can happen if you are keeping the lamps for more than 3 weeks. So that's the reason nowadays we recommend the lamps should be removed after 2 to 3 weeks. So this is the basic follow-up, like if it is a pseudocyst, wall of necrosis, plastic stent, lamps should remove after 2-3 weeks, plastic stent, get a MRCP to rule out any disconnected duct syndrome. If there is no leak, no need to do a ERCP. But if there is a disconnected duct syndrome, probably to leave behind the double pictet stent permanently. So this is the strategy to follow up after the post pseudocyst drainage. So summarizing the talk, we need to understand how does the pancreatic fluid collection spread. We need to understand the indications. We need to keep everything ready. Although it may look simple procedure, sometimes we may end up with many issues and we need to have a good backup of a colleague, a good backup of our endoscopy team. Our endoscopy technician is absolutely important and we should be ready for the worst and hoping that this will be our best procedure. Thank you so much for your patient hearing.
Thank you.